Hey everybody. This was a lecture I just gave to my department, but I thought it'd be kind of useful, so now it's on YouTube. This one is called Point of Care Ultrasound for the EM Clinician. Studies your radiology department does not perform. So I think these are the kind of bread and butter of ultrasound studies that our radiology techs and our radiologists read, at least in my hospital. That's going to be echoes, aorta ultrasounds, uh, DVT and arterial duplexes, all your biliary studies, renal appendices for children and thin adults, and then finally Doppler when it comes to pelvic and scrotal ultrasounds. These are kind of the gold standards for their respective applications. And while our radiology department does a great job at these, if we as EM clinicians and people at the bedside are empowered to do these, I think we can get people diagnosed, treated, and disposed faster, which is great for our patients. Um, Now, there are a plethora of instruction and research on how to do these right. And that's not what I want to make my talk about. Instead, I want to talk about things that only we can do, that at least in my hospital, radiology does not do. And these are the bedside ultrasounds that we own. That's going to be our extended fast in trauma, looking for pneumothoraxes, uh, pleural effusions, pericardial effusions, and intraperitoneal free fluid. Uh, Lung and thoracic, soft tissue, and MSK. The first of which I think anyone who is training in any EM residency or trained in the EM residency in the last 10 years already has pretty good experience with. And so we won't focus on that, right? Instead, I want to show you some of these nuanced studies that I think can bring a lot of utility to your practice. All right, let's start with lung, particularly pediatric lung, which is where I find the most utility. We all see these 3 10-year-olds who are coughing, febrile, look kind of in the middle, and you're like, I don't hear much on my auscultation. I really don't want to get an X-ray. Well, do an ultrasound. Takes less than a minute. Um, and I think you can see a full spectrum, in this case, of pneumonia and consolidative infections way better on ultrasound than even on X-ray. So these are a couple of clips. This one is done in a coronal view, so kind of cutting folks like this. Um, and we are going to see these little rib shadows. So rib shadow right here. And this is going to be our pleural line. Head is going to be over here. Feet is going to be over here. Posterior, anterior. And so as I play, notice, I'll play this a couple times. Notice a thin, smooth pleural line on the superior one. And as you look inferior, the liver is actually right here. This is the diaphragm, the liver. And there is something that doesn't look like nice, bright lung in between. Let's play that a couple times. Yeah. And some people will say, ooh, I see a beeline. I see something shining bright down, but that's not quite a beeline because beelines come from the pleura, right? The pleura is up here where my cursor is. This beeline is coming from somewhere deeper down. All right. So this is a small consolidation, subpleural, right underneath that pleura. And you notice there's a little bit of air coming down. This is less than the uh, width of a rib space. This is someone who has probably a little bacterial process going on, getting it some oral antibiotics and actually did fine. Now I'll show you a little bit more severe of a case. So same view, all right, going coronal. And now Notice here, here's pleura, here's rib, here's rib. There's a consolidation going from one rib space all the way down, going to the next. Look at the size of this thing. All right. And now, to take a better look at it, I'm actually going to turn my probe 90 degrees, and we're going to look at it in a transverse view. So same area. Notice now when I'm transverse, because now I can see the actual curvature of the pleura, it looks like a nice kind of U shape, and I don't see the ribs anymore. But notice, basically, the entire lung is filled with the consolidation. Take a look at this. There's no healthy pleura left. This is the pleural line, and everything is dark. Some people call it hepaticized, right? It looks like liver. But what I keep my eye on is actually these bright moving lines. See these guys right here? These are actually air bronchograms. So imagine that entire lung is just flooded in inflammatory fluid, pus, and what is left of air is just what's in the bronchioles. So these are air bronchiograms on ultrasound. This patient ended up having a pretty gnarly multifocal pneumonia, ended up needing supplemental oxygen, antibiotics, and fair few days in the inpatient setting. So mild, little bit of pneumonia, big ones. Or you see nothing, and nothing would just be kind of this nice, clear, bright line here. You see this, and again, these are cases we're doing bilateral, anterior, lateral, and posterior. You see these everywhere you listen to your lungs? Probably nothing consequential. When you start seeing these consolidations, that's when you got to think, uh-oh, something's a little off. All right, let's move on to soft tissue. This is the case, I want to say like a 16-year-old coming in with some pain on his back. And this is me kind of scanning the affected area. So a couple things I want to point out. This is, use a fairly obese kid. Notice this is, a lot of this is just all adipose tissue. But if you keep your eye up top, notice this adipose tissue looks a lot different than this. Notice down here, it's a lot more homogeneous. And up here, you have kind of, you can really see these globules of fat, and they're kind of like highlighted in between, which this is what we call cobblestoning. It's a sign of tissue edema, and in the right clinical context, is going to be a cellulitis. So this is at least cellulitis, and clinically it looks like cellulitis. All this cobblestoning, you see that? And then we see this big old glob right here. And this is actually our abscess. So he has both an abscess and uh, cellulitis. So I actually, because of cosmetics, made a fairly small incision here, cut into the abscess. A lot of pus came out. I scanned it again, and I still saw a meaningful amount of pus left here. And so I just want to show you kind of a new, not a new skill, but a nuanced skill I think can be helpful, which is kind of a sonographic abscess exploration. So notice I am scanning a little off plane at a different angle, so not directly over where my incision drainage is. And here I have my hemostat, and I am actually breaking up the actual part of the loculation of this abscess. And I know I'm not smashing into his tissue. I can see where I am, and I'm breaking that up. I pull out, and then more pus came out. And so when you're unsatisfied with your abscess, take a look at it again. Make sure you're not missing anything that you're having that you should be drained. Okay. This is a older gentleman coming in here with a month of swelling underneath his armpits. Notice the measurements on the side. We're getting close to 7 centimeters, which is kind of the max of what my ultrasound probe can do. And we're not even seeing the end of this abscess, right? Here's a little bit of musculature. I think this is pleura because we're looking lateral to medial. Maybe a little muscle here, but over here, I can't even see the end of that abscess. And notice here, you see kind of like this swirl sign. So as that, just the motion of me being on top of that abscess, and unfortunately, this is fairly painful for the patient. But just scanning that patient, you can see kind of pus swirling in and out. And the reason I bring this one up is typically if you can't see the bottom side or the deep side of your abscess, you probably shouldn't be draining it. Um, who knows what's over here? Giant blood vessel, a nerve, just because, and things that are this large tend to need intraoperative management. And so this is a patient who ended up getting antibiotics. We talked to our general surgeons who also thought this is more appropriate for them to take care of. Got a CT scan, saw it kind of necrosing all the way inside his chest wall, and needed certainly some surgical intervention. So simple little abscess, yeah, take care of the bedside. These big guys definitely need surgical help. All right. Now, this is a teenager coming with a painful red swelling underneath the neck. Hard to say if it was fluctuant or firm because they were just in so much pain. But take a look at this thing. And my question for you is, should we drain this? Looks like a big old abscess right here and another big old abscess right here. Yeah, has that same gritty characteristic. Well, before you do, my one tip advice before draining almost anything is make sure there's no color flow on it. And so when you look at these two structures again, this was with color Doppler, you'll notice there is a lot of perfusion, particularly in the core, the center of that structure. So I'll pause it right here. You'll notice, especially in this one right here, this kind of tree pattern where it's a central trunk. Actually, ooh, look at my tree background. But look at it's a central trunk and these branches that come off like this. All right. This is kind of a typical appearance of color for lymph nodes. So this patient ended up having a urinary lymphadenopathy or lymphadenitis. And just notice every one of these structures that looked, again, without color. I mean, you can convince me. And as someone who reviews a lot of ultrasounds, if you don't show me color, I could be convinced that's an abscess. But I promise you, if you put a knife in there, you will bleed and bleed and bleed. Please do not cut into uh, lymph nodes. And for simplicity, this is kind of a rule I give my residents. If something is shining on color Doppler, your knife stays away from it. Whether it's a fistula, whether it's an AV malformation, or whether it's a lymph node. If it's this vascular, it's not something that should be drained, or at least not drained by you. So these are lymph nodes. And now I'll go into another case that kind of has the same history. Same thing, atraumatic, no fever, but swelling right here on the side of that jaw. And again, you can convince me maybe this looks a little bit cellulitic, cobblestone-y, but keep in mind, this, where my cursor is, this is the fat layer. This is fascia. This is something deeper down, right on top of the bone of the jaw. And you're like, maybe it's a lymph node. So then you go in and you put color on it, and you're like, it's not really, particularly the core, it's not quite shining. What you'll notice is a lot of kind of these intricate ducts, kind of these darker pathways you can see in there. And they're not blood vessels because they're not shining out with color. So this is actually a parotid gland. Um, this is a patient who had peritonitis, probably viral, and did not need any knife near his face. And I just want to show you that structure again. Nice kind of globular, almost looks like cellulitis, but it's walled off, and you can see here, this feels like its own structure. It's a little bit vascular, but not quite as vascular as our lymph nodes. All right. Rib fractures. I think these are probably the most fun thing to do, and particularly if they are minimally displaced, you won't see them at all on X-ray. So if you have a 90-year-old who got ran over by a bus and they're like, my whole chest hurts, they have crepitus, this is probably not the best study. Like that's someone you're going to get a CT for. But in your very healthy young people who don't have a pneumothorax, and they're like, ooh, it hurts right here. And they can really point with one finger. That's a very quick study to just put your probe right on top of it. And here, typically, I go in the direction of the ribs, which is going to be transverse with maybe a little bit angle, depending if you're on the side. And you can see here, uh, fat. This one was a little bit lower, kind of below the pectoris, and so you don't have as much muscular. So you have skin, fat. These are going to be your internal and external obliques. And here is the contour of that rib. And you can see smooth, 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 crack right there, smooth. And this is me kind of fanning around. Notice as I fan out of plane of that rib fracture, I also get a look at the pleura. And so this is someone I knew had a rib fracture, displaced about a millimeter or two, but also did not have a pneumothorax underneath. And you can also take your time, look at the rib above, look at the rib below. And again, this was a unilateral single rib fracture. Did not need any surgical intervention. This is actually a patient that they missed a rib fracture on X-ray. But I will say he felt very validated when I told him, hey, you have a rib fracture, you're broken, your pain is certainly real. And I find one, this helps get patients seen quicker instead of waiting for their X-ray. And they just feel nice, at least knowing that, like, hey, you found something. This is another case. This rib fracture is actually posterior. And when you have posterior rib fractures, notice there's just a lot more fat, a lot more muscle. People tend to have a lot more muscle on the backside of the ribs than the front. So it's a little deeper, harder to see, but notice where my cursor is, this is the pleural line, and here is your big breakoff point. So this is also a single posterior rib fracture, did not need X-ray, did not have a pneumothorax, got disfilled quickly, and with appropriate management. All right, now let's talk about pediatric skull. Ooh, kind of just like rib fractures, but these I think are really useful for your kids that fall, have a big old bump on their head, and they're kind of an equivocal for a PCARN score. And you're debating, do I get a CT scan on this kid? Well, put your ultrasound right where that hematoma is. This is a kid who had a pretty sizable hematoma. I'll pause right here in the middle. And you'll notice this is skin, soft tissue, pretty a lot of edema in that scalp. And here you can see the hematoma, thin layer right on top of the bright bone. And I'll play a couple times. And unfortunately, most of these kids are moving, and so you only get a quick glimpse at it. But notice that bone line is nice and smooth with that hematoma. So this was an isolated hematoma without skull fracture. Now let's take a look at a different example. Notice here, soft tissue hematoma. All right. And now we're seeing some of the periosteum fascia coming off of that. And keep your eye right here on that skull. Notice on the right side of the screen, there's a pretty sharp cutoff. So that is a skull fracture. This is a patient I took care of, also under a year old, had a big old bump on his head. Mental status actually was just fine, awake, um, acting themselves. But I was like, the history didn't make sense. That hematoma looked a little bigger. Um, and when I pushed on it, they were crying. So this is someone who I got a CT on. And thankfully, my radiology department does these 3D reconstructions. And so you can actually see the skull fracture right here. Their hematoma was probably a little bit more superior. Notice there's a suture here, no suture back here. And you can see very obviously, this is a suture line. This is something that does not belong with a little bit of displacement. See that little lip right there? That was a fracture. And one thing I want to point out is the bulk of the hematoma was over here, and the fracture actually was a little off the side, which is typical for a lot of skull fractures and peds. So wherever you see the big bump, always look a little bit to the sides of that. Um, And this patient also unfortunately had a small subdural that did not need to be surgically intervened on. And so here are a couple images of sutures. Notice sutures are nice and smooth. And what I mean by that, the edge of that bone, you can see it's nice and kind of smooth off. And the thing I think about it is like, it shouldn't hurt you to put your finger, if you, hypothetically, didn't, touch the bone. If you touch the bone on a suture, it should be nice and smooth versus if you touch a skull fracture like this one, it would hurt. The other tip I have is don't forget sutures are symmetrical. So if you see something and you're like, that looks funny, go on the exact same side, like a mirror image. If it's there, probably a suture. And if it's not, it's probably a fracture. So again, super fast, fairly easy, no radiation. And anyone who you think even remotely has a fracture, it's a nice way to be like, hey, I don't see anything, or whoops, something looks funny. I need more imaging. This is a study I've been doing a little bit more now, which is looking for nasal bone fractures. I typically like going in a transverse view, so going from kind of the eyebrow down and looking at the contour of the nasal bone itself. This was a kid that got hit on the head with a baseball like the day before. I wasn't going to CT him, particularly because I wasn't really concerned about anything intracranial. So starting from top down, notice nice smooth contour. And as I scroll down towards kind of the tip of the nose, notice one, it sharpens up. So a little more blunt here, a little more sharp here. And you can see there's a non-displaced fracture right there. I have a different clip of that same patient. And notice on the healthy side, everything's nice and smooth. And here you have a little bit jagged, non-displaced fracture. A little bit of, you can see a little hematoma right here as well. And again, these are patients who typically don't need any operative management. They heal fine on their own. But I will say patients find a lot of satisfaction when you can show them the fracture and be like, yes, you are validated. You do have a fracture. Even though the management's the same, a lot of things you can tell clinically. If you show them what it is, it really helps them feel like they were really assessed. So yeah, this is a nasal bone fracture right here. And then here are some more images. This one is a lot more displaced. Notice it basically got rotated in. So the central part of the bone is kind of displaced on this side and kind of going up on that side. This is another example of a small, less displaced nasal bone fracture. But again, fairly easy to do. Just use lots of gel so you're not actually like pushing down on their broken nose. All right. We'll finish off with some shoulder ultrasound. So if you haven't done this, definitely practice on someone who with an intact shoulder. Whether what the view is you're kind of going from behind them. You can also do this anteriorly, but I find the posterior actually much easier to do and interpret. But what you're going to do is you're going to view from behind them, start somewhere around the humerus and wrap around medially until you see the spine of the scapula. And so typically the head of the humerus is going to look like a nice smooth ball. And then as you move medially, you're going to see kind of this bone stick out. This is going to be your spine. This is going to be your glenoid joint. And then over here up top, you see your deltoid as the first superficial structure. And then deeper than that, you see your rotator cuff inserting into the shoulder. This is a healthy shoulder, and this is one I'm actively kind of turning to make sure there's the concern was, this in this patient was a tendinopathy or a tendon rupture, and I just want to make sure they were able to kind of move under ultrasound guidance. Notice a little bit of fusion around the head of the humerus. That is typically normal to see. All right, so this is a normally non-dislocated shoulder. Notice that the spine of the scapula and the head of the humerus are on the same height. And what I mean by that is they're the same distance away from the ultrasound probe when you look from behind. And that means they're in line, which they should be, right? You're articulating against one another. And so this is a intact shoulder. This, right, because my probe is up here. My probe is posterior. So if I move closer, if my head of the humerus moves close to the probe, that's going to be a posterior dislocation. And if it moves away, that's going to be an anterior dislocation. I'll show you an example of both. So here, we're on the opposite side. So now this side, our left is going to be lateral, right is going to be medial. Notice, one, that the spine of the scapula is where we expect it to be, and there's a gap, and that head of the humerus doesn't line up smoothly. It's displaced anteriorly. And so this is a patient who I think had recurrent shoulder dislocations, was putting on a dress and then felt something pop, couldn't get it back. Within seconds, I was able to confirm this was in fact dislocated. I didn't even get an x-ray because it was atraumatic. Gave a little bit of massage, some pain medication, and was able to reduce it. And so on the right is the reduction. And this kind of looks just like our first image, where the side of the scapula and the head of the humerus are nice and aligned. And notice the other thing, which is one of the reasons why it's so painful, here on the right, we have our intact rotator cuff attaching to the lateral side of the humerus. Here we can see that tendon is being basically stretched out way longer than it should be. But yeah, this is going to be an anterior dislocation. This I find the most useful is when you have very obese patients and you can't even tell clinically if it's in or not. You hear a little bit of click, particularly folks who are getting sedated, and you're like, I don't know if I need to pull more or if there's someone that I can stop on, right? Instead of sending them to radiology and having them come back, just grab your probe, go from behind. If you see this, that means you got to keep pulling. And if you see this, you're done, right? As opposed to I've seen examples of folks who are unsure, send their radiology, they come back 30 minutes later, it gets read as still dislocated, and they have to resedate again, which is a shame. This is a patient who was having multiple seizures that were uncontrolled. And so they were in kind of the resus part of our department. And there they were just getting portable x-rays. The clinician, I got a sign on this patient. I wasn't the first person who saw them. But the initial clinician saw them and thought they should have looked a little weird. They were post-ictal, so they couldn't get a history. But decided to get an AP x-ray because that's all you get in resus's. They don't do the lateral or the axillary views. And so on the AP, it actually was read as being intact. This was a dislocation. And as you can see, it's closer. The head of the humerus is closer to the ultrasound probe. So this is actually a posterior dislocation. This is a posterior dislocation that did not have much displacement left and right or up and down. And so when you take a nice AP, it's directly behind, but in the right spot. So the radiologist read it as being intact. I got signed out on this patient like an hour later, and I did the ultrasound, and I was like, uh-oh, that is definitely not an intact shoulder. And so this was a patient that we had to sedate, and with some help, got them to be relocated again. So notice spine of the scapula here, head of the humerus way closer. You can see these are the musculature up here, and then there's a big old hematoma right there. All right. Okay, and to close things off, this is probably one of my favorite ultrasound studies to do. Uh, Not the best pathology for people to have, but I find it really satisfying to find this pathology, which are Achilles tendon tears. Um, so these are studies that are done prone. So somebody is face down, heel up. And you can imagine if this was my foot and this is the heel, you are scanning them like this in a long axis, following their heel and going up. And so on this study here, head is going to be to our left, heel is going to be to our right. This is going to be the calcaneus, kind of following the bone up. And notice this is a lot of the soft tissue connectors. And what's most proximal to the ultrasound probe is going to be Achilles tendon. And so this was done at one of our community sites. One of the patients I saw at the community sites who did not have the fanciest ultrasounds there. But notice there is tendon, 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 and now there is just a hard stop. And so this is a classic full tear. And to be even more precise, I then did it under, this is basically a dynamic Thompson's test, where I'm squeezing the calf on the left side and I see if their foot is moving. It wasn't moving, but this is me actually visualizing it. And so you can see I'm putting pressure on, and you can see that gap gets bigger, right? Because there's a full tear. And just as an example of a normal Achilles, this is another paper. On the right, you can see a nice intact tendon where you see those bright white lines running left and right all the way across the screen. And it's particularly for like adults and taller patients, you may have to take multiple clips going from starting the heel up, 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 up. Sometimes with partial tears, you may see a lot of fluid around here, but you'll see at least a lot of the most of the fiber is still connected. Versus a complete tear, you'll see a big old fluid pocket here and then two sides of a tendon. And again, you don't see this at all on X-ray. Who's CTing an ankle or getting MRI on the ankle in the ED? Not much. And so this is somebody who you can really get a fast dispo and really help coordinate their management between, oh, you have a little tendinitis, here's some NSAIDs, stretch, versus, uh-oh, that's a full tear. We'll put you in a splint and you'll see ortho tomorrow. Yeah. So hopefully that's all I have for you. Hopefully I've empowered you to get more scanning done and complement what the studies you own to the one that your radiologist does. Thanks.